Okay, welcome to my class, and today we are going to learn the last but the most important section of the diseases of the breast. I think you might guess it's the breast cancer. The next step is the surgical treatment of the cancer. Through the mid-20th century, breast cancer was thought to arise in the breast and progress to other sites largely via centrifugal spread. In this model, more extensive surgical procedures were expected to reduce mortality by resecting local regional disease before it could spread to distant sites. It includes the radical mastectomy or extended radical mastectomy, which now we already know it is not the most proper way in treatment of breast cancer. In modern days, local and regional approaches, for example, surgery and radiation therapy, in addition to medical therapies designed to treat systemic diseases, because the extensive mastectomy didn't improve the survival rates because it could do nothing to the distant metastasis, which is more lethal. And the picture on the left hand shows the radical mastectomy, and the picture on the right hand shows the breast conservation surgery. And which one is better? Not only the patients ask, the surgeons also doubt about this. Is that breast conservation feasible? Is that the same effective as the radical mastectomy? So there are a lot of trials to do to evaluate the mastectomy versus breast conservation treatment. 6 prospective clinical trials have randomized more than 4,500 patients to mastectomy versus breast conservation therapy. In all these trials, there was no survival advantages for the use of mastectomy over breast preservation. Ipsilateral breast recurrence rates were higher in patients undergoing breast-conserving surgery, but local recurrence could be salvaged by mastectomy at the time of recurrence, with no significant detriment in survival rates. And they also evaluate the radiotherapy and radiotherapy plus lumpectomy and the simple lumpectomy. And they found in addition of radiotherapy, the local recurrence dropped dramatically. The cumulative incidence of a first recurrence of cancer in the treated conserved breast during 20 years of the follow-up showed here. And we can see, in addition of radiotherapy, they have the similar recurrence rate compared to the mastectomy, but a little bit higher. But very recent, there is a meta-analysis to evaluate the mastectomy versus breast conservation treatment. And they came to a conclusion that the breast conservation patients have better survival, and the overall survival are much higher than the mastectomy group, even though with a little bit higher recurrence rate. Is everybody is suitable for the breast conservation? Unfortunately, I have to say no. There is some eligibilities for breast conservations. Breast conservation is considered when the tumor can be excised to clear margins and leave an acceptable cosmetic result. and local recurrence rates are reduced when 2 to 3 millimeters microscopically clear margin are obtained. And local recurrence rate can somewhat higher in younger versus elder women. The local recurrence rate are reduced in patients for all ages with the use of radiation therapy. So the eligibility includes the tumor size, the location, the one under the areola is assumed to be not suitable for breast conservation because of the lymphatic plexus. And the non-multiple centric, which we couldn't have the clear margin. And the age, elder age are safer. And no combined diseases unsuitable to breast irradiation. And the next step is about the treatment of the axillary lymph nodes, the local regional lymph nodes dissection. Axillary lymph node dissection used to be carried as a routine component of the surgical management of breast cancer patients. It provides prognostic information and the removal of the positive nodes. But the post-operative complications of the axillary lymph node dissection includes immediate problems that includes acute pain and paresthesia, needs for hospitalization, reduce the range of motion at the shoulder joint, and need for drain in the surgical bed for a period of 2 weeks or even more. The long-term problem include lymphedema of the ipsilateral arm, the numbness, the chronic pain, and the reduced range of motion at the shoulder joint. So as the patients are more early to be detected, there is another way to evaluate the axillary lymph node called sentinel lymph node biopsy. By removal of the first one or group lymph nodes, which drainage the area of the primary tumor after lymphatic mapping, those patients with the negative sentinel lymph nodes can avoid the morbidity of axillary dissection. The lymphatic mapping can be performed with a combination of technetium-labeled sulfur colloid and a vital blue dye or nanocarbon particles. They can be used individually or combined together for localization of the sentinel lymph nodes. And I think the concept of sentinel lymph nodes, you should memorize that. After the operation, the systemic treatment of breast cancer is in need. For stage 1 to 3 invasive breast cancer, the goals of treatment for patients are curative. Treatment is considered in the context for the potential benefits of therapy based on the reduction of risk of recurrence, as well as the potential harm of the treatment. Despite advances in local regional therapies, a significant proportion of women with breast cancer will develop metastatic disease within 5 to 10 years after diagnosis. A systemic approach of treatment with medication is used to treat and prevent recurrence of possible microscopic metastatic diseases. The main method includes chemotherapy, endocrine therapy, radiotherapy, and anti-HER2 therapy, and in addition of biological and immunotherapy. In general, the more risky of recurrence, the more treatment is received. And in the consideration of the subtype of breast cancer for the ER or PR negative, positive breast cancer, the endocrine play the most important role, while the ER/PR or HER2 negative, the chemo plays the essential role, while the HER2 amplification subtype, the anti-HER2 is the most important method. At last, I'll introduce the neoadjuvant therapy. It's a concept refers to the therapy before the operation, including chemotherapy, endocrine therapy, and the radiotherapy, and anti-HER2 therapy. Patients with local advanced breast cancer tend to receive neoadjuvant therapy to improve their prognosis. And this table shows the common drugs in chemotherapy, just have a general view of that. Okay, this is the end of our class, and thank you for your attention. Thank you.